Assalamu alaikum. It's a high-yield topic regarding obstetrics. Start with this placenta. Antepartum hemorrhage are of two types: placenta previa and abruptio placenta. What is placenta previa? When there is bleeding, which is painless, causeless, recurrent, and it is antepartum bleeding after 20 weeks. That is placenta previa. And if the bleeding is due to painful cause present, it is abruptio placenta. It's very simple manner. I'm talking about a very simple manner now. Abruptio placenta means placental detachment from uterus before fetal delivery. What does abruptio means? That means placental detachment from the uterus. Placental detachment from the uterus during delivery. It may be due to hypertension, preeclampsia, prior abruptio, preterm, premature, pre-rupture, uh, preterm, pre-labor, rupture of the membrane. If drugs used like cocaine and tobacco, and if there is abdominal trauma, these are the actual cause of placenta previa. So again, I would like to keep in mind that hypertension, preeclampsia, there may be some drugs, tobacco, cocaine, prior abruptio placenta, preterm, pre-labor rupture of the membrane, preterm, pre-labor rupture of the membrane, abdominal trauma. Clinical presentation is sudden onset vaginal bleeding. Clinical onset is sudden onset vaginal bleeding, abdominal or back pain, sudden onset vaginal bleeding, abdominal or back pain, high frequency, low intensity contraction, rigid, tender, distended uterus. Rigid, tender, distended uterus. Diagnosis is clinical ultrasound with or without retroperitoneal hematoma. Complication is fetal hypoxia, preterm birth, and mortality. Fetal hypoxia, preterm birth, and mortality. And complication there is maternal hemorrhage, DIC, maternal hemorrhage, and DICs. Although most patients develop vaginal bleeding, to 20% have a concealed abruption in which there is no visible bleeding. Patients with concealed abruption typically have severe focal pain at the location of the placenta, mid-epigastric pain, then progress to the diffuse uterine contraction. Cocaine and tobacco use are potent vasoconstrictors that readily cross the placenta and can cause placental vasoconstriction and ischemia. The ischemia can then cause necrosis and hemorrhage at the uteroplacental interference, resulting in subsequent detachment of the placenta from the uterine wall. As blood accumulates between the placenta and the uterine wall, the intrauterine pressure increases and induces and uterine irritability, chronic hypertension, regardless of blood pressure control, is a risk factor due to underlying maternal endothelial dysfunction. This dysfunction impairs normal delivery of the spiral artery. This dysfunction impairs normal delivery of the spiral artery that supply the blood to the fetus and placenta. The result in abnormally high resistance spiral artery that lead to low placental perfusion, ischemia, possible infarction. Placental abruption can occur. Okay, blunt abdominal trauma. Blunt abdominal trauma, motor vehicle collision in pregnancy can cause severe maternal bleeding and hemorrhagic shock. Severe maternal bleeding and hemorrhagic shock. Trauma patients in hemorrhagic shock require placement of intravascular volume and transitioning from crystalloid to blood product resuscitation as soon as possible. So blunt abdominal trauma is one of the cause of this abruptio placentae, and placental abruption can occur following gush of amniotic fluid, particularly in patients with uterine overdistension like twin gestation polyhydramnios, because the sudden loss of volume leads to uterine decompression. Chronic hypertension, regardless of blood pressure control, is a risk factor due to underlying maternal endothelial dysfunction. This dysfunction impairs normal development of the spiral artery that supply to the fetus and the placenta. The results in abnormally high resistance spiral artery that lead to low placental perfusion, ischemia, possible infarction. We know that in massive transfusion protocol, if there is heavy bleeding, 1:1:1, that means red blood cell, platelet, then plasma, red blood cell first, then platelet, then plasma. To avoid coagulopathy for dilution of the platelet on the emergency cesarean delivery after maternal trauma may be indicated for imminent fetal compromise. Management is dependent on maternal and fetal stability. Acute abruption with active bleeding and evidence of fetal hypoxia require emergent delivery. Some cases of abruption placentae are self-limited and clinically insignificant. Placenta accreta. When placenta attached to the myometrium, morbidly adherent placental attachment to the myometrium is called placenta accreta. Placenta previa plus prior uterine surgery, cesarean delivery, DNC, and myomectomy is the risk factor. Placenta previa plus prior uterine surgery, cesarean, DNC, and myomectomy. Clinical feature is prenatal diagnosis, ultrasound with placenta previa, numerous placental lacunae, myometrial thinning. Postpartum diagnosis is adherent placenta and PPH, and management is caesarean hysterectomy with placenta in situ. Placenta accreta is morbidly adherent placental attachment to the myometrium. Risk factor is placenta previa plus prior uterine surgery, caesarean delivery, DNC, and myomectomy. Clinical feature is prenatal diagnosis, ultrasound with placenta previa, numerous placental lacunae, myometrial thinning, and postpartum diagnosis is adherent placenta and PPH. Management is caesarean hysterectomy and placenta in situ. It is the abnormal attachment of the placental villi to the uterine myometrium rather than the decidua vasalis. These abnormal placentation likely occurs due to defective or absent endometrial decidualization in areas with scarring prior to uterine surgery. Common findings include low-lying placenta and signs of abnormal placental attachment or invasion into the uterine wall, such as myometrial thinning and numerous placenta lacunae, vascular spaces filled with maternal blood. Placenta accreta is usually diagnosed on routine second trimester ultrasonography. However, in some cases, limited prenatal care diagnosis occurs after the delivery when there is difficulty detaching the placenta from the uterus. Excessive traction on the umbilical cord typically leads to cord avulsion. Attempts to remove placenta, manual extraction, sharp uterine curettage are unsuccessful and can cause profuse bleeding. Therefore, removal of the placenta is contraindicated. Patient diagnosed prenatally. Patient diagnosed prenatally typically undergo planned cesarean hysterectomy to decrease this risk. But patient diagnosed at the time of the delivery usually require emergency hysterectomy to active hemostasis. The risk of placenta accreta is increased in patients with prior cesarean delivery and anterior placenta due to abnormal placental attachment at the uterine scale. Placenta accreta, normal accreta attached to the myometrium. Increta invades the myometrium or percreta perforates the myometrium. This is another very high yield topic, that is placenta previa. Risk factors are prior placenta previa, prior cesarean delivery, multiple gestation (PPM), prior placenta previa, prior multiple gestation, prior placenta previa, prior cesarean section, and multiple gestation. Painless vaginal bleeding more than 20 weeks of gestation. I have talked it in earlier initial session that painless, causeless, recurrent, usually causeless. There are some risk factor like prior cesarean, prior placenta previa, and multiple gestations. Diagnosis: transabdominal followed by transvaginal, transabdominal followed by transvaginal sonogram. Management is no intercourse, no digital cervical examination, inpatient admission for bleeding episode. Causes of painless vaginal bleeding occurs when the placenta extends over and covers the cervix. Is typically diagnosed incidentally on ultrasound. Most patients are asymptomatic and are incidentally diagnosed on second trimester ultrasound. Patient with placenta previa require pelvic rest, no intercourse or digital cervical examination. Because minimum cervical manipulation can cause cervical changes, shortening, dilatation that can result in partial placental detachment, massive maternal hemorrhage. Prior cesarean delivery is a major risk factor. Prior cesarean delivery is a major risk factor for placenta previa. Increasing cesarean delivery rates caused an increased incidence of placenta previa because the uterine scar changes in vascularity likely alter early pregnancy implantation. Additional risk factor: prior placenta previa, multiple gestations, and advanced maternal age more than 35. Advanced maternal age more than 35. Most cases resolve spontaneously by the third trimester due to physiologic lower uterine segment lengthening and placental growth toward the fundus. Patients with persistent previa should undergo caesarean delivery at 36 to 37 weeks of gestation prior to the onset of the labor. Repeat ultrasound is performed in the third trimester, more than 28 weeks of gestation, and patients with previa resolution can continue the routine care without pelvic restriction. Asymptomatic patient, no vaginal bleeding with persistent previa undergo scheduled cesarean delivery at 36 to 37 weeks of gestation. Digital cervical examination is contraindicated as digital examination enters the cervical canal. In contrast, speculum examination can be used to verify and quantify vaginal bleeding as it does not enter the cervical canal. Then vasa previa. Vasa previa can present with vaginal bleeding due to injury of the fetal vessel overlying the cervix. Vasa previa. Vasa previa can present with vaginal bleeding due to injury to the fetal vessels. There is injury to the fetal vessel injury within the Wharton jelly unprotected vessel at the internal os. It can present with vaginal bleeding due to injury to the fetal vessels overlying the cervix. However, the bleeding is typically painless, just like placenta previa. It is painless. Vasa previa, placenta previa, all are painless. It happens due to injury to the fetal vessel overlying the cervix. Injury to the fetal vessel overlying the cervix. This is vasa previa. Fetal vessel overlying the cervix are injured. It happens due to placenta previa, multiple gestation. It happens due to placenta previa, multiple gestation, in vitro fertilization, and succinturate placental lobe. Clinical presentation: painless vaginal bleeding with range of motion or contraction, fetal heart rate abnormality, bradycardia and sinusoidal pattern, and fetal exsanguination and demise. Emergency delivery should be done in such cases. So, fetal vessel within the cervix, risk factor are prior placenta previa, multiple gestation, IVF, and succinturate placental lobe. Painless vaginal bleeding with range of motion or contraction, fetal heart rate abnormality, bradycardia, and sinusoidal pattern, fetal exsanguination and demise. Management is emergency delivery, emergency cesarean delivery. Normal vital vessels travel in the umbilical cord surrounding the thick gelatinous tissue Wharton jelly that protects the vessel. In contrast, vasa previa is the aberrant condition in fetal vessel overlying the cervix, surrounded only by the fetal membrane. Their location over the cervix and lack of protection by Wharton jelly makes vessel. Their location over the cervix and lack of protection of Wharton jelly make these vessels prone to tear and rupture of the membrane. Vasa previa, typically diagnosed in middle anatomy. Vasa previa diagnosed at 18 to 20 weeks of gestation, and early cesarean delivery should be done at 34 to 35 weeks of gestation. So vasa previa diagnosed 18 to 20, try to deliver at 34 to prior to the onset of the contraction of the rupture, 34 to 35 weeks. However, vasa previa may be clinically diagnosed when patients present with rupture membrane accompanied by Painless. Rupture may be accompanied by painless, minimal vaginal bleeding. Vaginal bleeding is minimal because total fetal blood volume is low. Total fetal blood volume is low, 250 ml or 1 cup. However, hypotension from fetal bleeding leads to fetal heart rate abnormality, bradycardia, sinusoidal movement, rapid fetal exsanguination and demise. Management of a rupture fetal vessels with emergency cesarean delivery because of the risk of fetal exsanguination and demise. However, bleeding from placenta previa is primarily maternal blood loss and therefore usually heavy and persistent rather than minimal and transient. Now, umbilical cord prolapse. Uterine rupture. Uterine rupture commonly cause abdominal pain, uterine tenderness, and fetal heart rate abnormalities. However, patients typically have diminishing contraction and fetal pulse palpable through the maternal abdominal wall. Uterine incarceration, entrapment of the uterus between the pubic symphysis and sacral promontory is a rare condition. Uterine incarceration is a rare condition, typically occurring less than 20 weeks of gestation. Patients have constant lower abdominal pain that radiating to the back and uterine retention due to bladder obstruction. Uter and then pregnancy loss or ectopic pregnancy. Pregnancy lateral fusion defects the uterus. This is septate. This is bicornuate uterus. This is unicornuate uterus. This is ectopic pregnancy. Very high yield topic. Ectopic pregnancy is previous ectopic pregnancy, previous pelvic or tubal surgery (PID) and IVF. Previous ectopic, previous pelvic or tubal surgery (IVF) and PID. In ectopic pregnancy, abdominal pain, amenorrhea, vaginal bleeding, hypovolemic shock. If rupture ectopic pregnancy, cervical motion, adnexal and abdominal tenderness, palpable adnexal mass. Diagnosis positive HCG transvaginal ultrasound revealing adnexal mass, empty uterus. Stable methotrexate, unstable surgery. Stable methotrexate, unstable is surgery. Although most ectopic pregnancy implant in the ampulla of the fallopian tube, implantation occasionally occurs in the upper outer corners of the uterus cornua, where the uterine wall meets the proximal fallopian tube. Those are known as cornual or interstitial ectopic pregnancy. Specific risk factor for cornual ectopic pregnancy include uterine abnormalities, bicornuate or unicornuate uterus, and IVF. The cornual region receives an abundant blood flow from the uterine and ovarian vessels, and therefore rupture in this area to intraabdominal hemorrhage. The accumulation of blood can often seen in ultrasound as free fluid in the posterior cul-de-sac. An acute increase in pain with tubal rupture which can lead to hemiperitoneum with blood pooling in the posterior cul-de-sac results in the urge to defecate due to increased rectal pressure, including adolescents who may be reluctant to disclose sexual activity, who have unexplained vaginal bleeding and abdominal pain, require pregnancy testing. Spontaneous abortion inevitable can happen. This is tubal most common. Cornual or interstitial, ovarian, abdominal, cervical. 5 pattern. Tubal most common cornual, abdominal, ovarian, cervical. Management of suspected ectopic pregnancy. Risk factor is prior ectopic, prior ectopic IVF and multiple prior ectopic previous pelvic or tubal surgery IVF PID. Positive urine beta HCG, positive urine HCG, low abdominal pain, vaginal bleeding. Patient hemodynamically unstable, immediate surgical consideration. Patient hemodynamically stable, transvaginal ultrasound. If adnexal mass, treat ectopic pregnancy, intrauterine pregnancy, and non-diagnostic. Serum beta HCG more than 15,000, more than 1500. Repeat beta HCG and transvaginal ultrasound in 2 days. If less than 1500, repeat beta HCG in 2 days. So this is the way of treating a patient with suspected ectopic pregnancy. A patient with ectopic pregnancy, if hemodynamically unstable, immediate surgical consideration. If hemodynamically stable, do transvaginal ultrasound. If transvaginal ultrasound shows adnexal mass, treat for ectopic. Intrauterine pregnancy and non-diagnostic. In non-diagnostic, serum beta ICG should be done. If it is more than 1500, repeat beta ICG within 2 days. If it is less than 500, then at that time you also do repeat beta HCG only in 2 days. But TVUS should not be done in if it is less than 1500. Ectopic pregnancy management. If it is stable, no surgery. Stable, yes, beta HCG less than 5000 and no fetal cardiac activity. Oh, no fetal cardiac activity. Then methotrexate should be given. And beta is less than 500 and no fetal cardiac activity, no surgery. If MTX candidate contraindication, immunodeficiency, liver disease, renal disease, if these type of things present, if MTX candidate, yes, MTX therapy. If MTX candidate, but there is some contraindication, then go for surgery. Stable, no surgery needed. Beta HCG less than 5000, no fetal cardiac activity, no surgery is needed. MTX candidate, no surgery is needed. So management of ectopic pregnancy is either medical or surgical, depending on maternal hemodynamic status and ability to tolerate methotrexate therapy. MTX is a folate antagonist that inhibits DNA synthesis particularly in rapidly proliferating cell sideroblast. However, the large dose required for treatment can affect cell types, especially in patients with certain underlying condition. Absolute contraindication of methotrexate include the following: if there is hematologic abnormality, anemia, thrombocytopenia, immunosuppression, there is increased risk of bone marrow suppression and pancytopenia, so MTX should be avoided. In advanced pulmonary disease, MTX should be avoided because MTX induced lung disorder can happen. Hepatic and renal disease due to increased drug metabolism clearance, which increases the risk of methotrexate toxicity. ARDS and bowel ischemia. Breastfeeding due to transfer to breastfeeding due to transfer to the breast milk, which can cause toxic level in infant. In addition to having an absolute contraindication to MTX therapy, there is several relative contraindication including adnexal mass more than 3.5 cm, in the presence of fetal cardiac activity, and beta ECG level more than 5000. In patients with these findings, the best next step is surgical removal of ectopic pregnancy. Patient with pregnancy of unknown location, that is no visible intrauterine or extrauterine gestation, and abnormal beta ECG level indicates either ectopic pregnancy, non-viable intrauterine pregnancy, and anembryonic gestation. When the diagnosis is uncertain, patient may undergo diagnostic dilatation and curettage, a procedure that samples the tissue within the endometrial cavity. The procedure confirms the abnormal pregnancy location based on post-procedure beta ECG level. A decreased a negative or decreased beta ECG level confirms that the patient had abnormal intrauterine bleeding. These patients require reassurance and observation only. Patients of abnormal products of conception removed by dilatation and curettage. And in contrast, a persistent rise in beta ECG after dilatation and the curettage for ectopic pregnancy. The uterus have an evacuated and extrauterine pregnancy continues to produce beta ECG. These patient requires additional management. Per persistent rise of beta ECG after DNC is diagnostic for ectopic pregnancy. The uterus have been evacuated, but an extrauterine pregnancy continues, which will produce these beta ECG. Methotrexate is the medical treatment for ectopic pregnancy in patients with hemodynamic stability, no renal, hepatic, hematologic problem. These patients should be low beta ECG level, and beta ECG level is low, less than 5000. After treatment, patients require monitoring of the beta ECG level until they become undetectable to ensure the treatment is complete and patient has no longer risk at risk of tubal ligation. Then pseudocyesis. Pseudocyesis means a, a condition in which non-psychotic woman with signs and symptoms of early pregnancy, amenorrhea, morning sickness, abdominal distension, breast enlargement, and the belief that she is pregnant. Evaluation excludes pregnancy typically via negative pregnancy test and ultrasound, normal empty uterus, risk factor, history of infertility, and prior pregnancy loss. Pseudocyesis likely occur when somatization and stress affects the hypothalamic Pituitary excess causes early pregnancy symptoms when bodily changes and weight gain amenorrhea are misinterpreted. The end result is non-psychotic patient who believes that she is pregnant. The belief is strong enough that the patient misinterprets negative home pregnancy test as being positive. Because pseudopsoriasis is a form of somatization and management requires psychiatric evaluation and treatment. And that's all about this. Hope you enjoyed.